Okay, so we're live. Hi, everyone. Welcome to today's webinar by Mind the Bleep on preparing for on-call and common bleep scenarios. This is a webinar as part of our 10-part series of the FY1 Survival Guide. Today's talk will be held by my colleague, Dr. Nihal Chanian. He's an FY1 working in the West Midlands. This talk is also being recorded and will be available to watch on the YouTube channel, the Mind the Bleep YouTube channel and Meadow. But also be sure to check out our other videos as part of our FY1 Survival Guide available on the YouTube channel. In the chat box, we'll post the link to feedback forms. So on filling those out, you get a certificate of attendance. Throughout this talk, also put your questions in the chat box and we'll try answer all of them at the end of this talk. This talk is being sponsored by the BMA and the MDU. From the BMA, we have Daniel, who will give a short presentation, and then we'll run a video from the MDU as well before Nihal goes on to deliver his talk. So without further ado, I'll pass you on to Daniel.
Okay, cool. You should be able to see my screen now. I've just put something in the chat as well. So yeah, hi everyone. I'll be super quick. So I'm Dan. I work at the BMA. Well done. Congratulations once again on becoming doctors, and I hope you're looking forward to the next couple of weeks and inductions and whatnot to come. So just before we begin, you'll see there's a massively overwhelming big text on the screen, and yeah, this is basically the biggest offer we've ever had. If you're not a member of the BMA already, if you use the QR code that's on the screen or the link I've just put in the chat, you'll get free membership until October the 1st. That's 2.5 months free membership, what is a vital time to be a member. So don't miss out. All you have to do is use that QR code or use that link, so it goes to the same place, and just apply for membership. If it says at any point you're going to pay whatever a month, you're not. Don't worry, it's going to get waived as long as you've used that link. If you're unsuccessful joining as a doctor, as an F1, just try it as still being a student. We're just waiting. The GMC are feeding through the GMC numbers, so we haven't quite got everyone yet. So it may be a bit of trial and error of joining as an F1, but just joining as a final year student still. So sorry, it's a weird time for us getting GMC numbers. So from October, membership will be £9.91 a month, but it's £7.93 after tax relief. So you do get tax relief back on what you pay. So you don't have to stay beyond October as well. So you can stay because that's the end of our membership year, and then leave from then. You can leave from whenever you want. But yeah, I would definitely say at least join for the next 2.5 months. And use the contract check, use some of the tools that I'm going to talk about, and then it's up to you whether you stay beyond that. Definitely, best thing to do is just be part of the BMA for at least the next 2.5 months. It's a pretty vital time. So just a little bit about membership. I'm sure you are all members, or you've been members at some point, so you know what we do, what you sort of get as being a member as well. A little bit of a refresher, and hopefully you might find out something new as well about the BMA and what we do. So obviously, the main thing what we are the Trade Union Professional Association for Doctors in the UK. So we act as the voice of the profession, representing you individually, locally, and nationally on all the issues that affect you. So while it's your job to look after patients, our job's to look after you. You're going to hear from MDU next. Sometimes we get confusion with indemnity. We're not an indemnity company, so we're not like MDU, we're not like MPS. We don't deal with patient complaints. We're your union. We're here to look after you, your working conditions, so things like pay, contracts, your professional development, also your well-being as well. Some of you who are members would have started to get messages about the ballot that we're going to run later in the year. So we're looking for full restoration of pay to begin with, so 30%, and there will most likely be strike action and strikes sort of the start of next year, with the ballot sort of coming towards the end of this year. So even more reason to be a member. We'll be striking, it looks like, sort of start of next year, like 2016, if you guys can remember that. So just in terms of sort of day-to-day stuff that you can use us for, we've got the BMA library, which is all turned sort of into like ebooks now. We used to it was mainly a postal service that we used before, but now you can just access things instantly from anywhere. Which you can just open through our website or on your phone. Clinical Keys is a new tool that we've got as well. So as a medical search engine, you may have had it at med school. You can continue to use that through BMA membership. You also have access to our clinical, non-clinical learning tools. So you've got full access to BMJ Learning, which has over 1,000 clinical, non-clinical modules. There's also courses that are really helpful for completing your e-portfolio when you start F1, and it's all very interactive and kept up to date with obviously practice change developments. For each module we do as well, you can print off certificates as proof of learning. Very early to think this, but if you're thinking about your specialty options already, you can use our Specialty Explorer tool, which can give you a bit of a better picture of what suits you best. So that one's an online psychometric test, which takes about 20 minutes to complete. It'll ask all sorts of work-life balance questions, and it will give you a really detailed report listing all top specialties according to the answer you've given. Really, really easy to use, and covers all specialties, and the reports are very thorough. Lots of analysis of your answers. Sorry about that, Doug. Really good to do this at different parts, different points as well in your career. So sort of do it now, and then sort of a couple of months into F1, do it again and see sort of how your tastes change. Really good tool. We've got a really good wellbeing service. So if any time you'd like to speak to someone about your wellbeing, we've got our services open 24/7 to all students and doctors, and have the choice to speak to a counsellor or a peer support doctor. It's telephone based, and we do offer video calls as well if you prefer that. And we'll also make sure you speak to the same person if it's more than a single call to the service. Completely confidential, obviously, free of charge and open to everybody. So that one's regardless of whether you're a member or not. It's open to all. Probably the biggest thing to tell you about, and probably the biggest thing for you to use sort of in the next month or even now, if you've got it, is our contract checking service. You might have come across this already. We'll check it within 5 working days, comparing it to a national model that we negotiated with the government back in 2016 and then again in 2019. And if there are any issues, we can help get them sorted. So it's not always on purpose, but extra bits can be slipped into your contract, or trust can change the wording to mean sort of something opposite to what it should say. We're finding this is quite common, sadly. We just want to make sure it's correct and you're getting what you should be. So you'll see on the screen, it's quite a damning statistic. 25% of the contracts we checked last year were wrong. So 1 in 4. It's just too high a number for something that was negotiated and should be standard. So let us check it before you sign it. If you have signed it, it's fine. We can still check it and get it sorted, because you shouldn't have been given a wrong contract. Just don't let it be that 1 in 4, and don't sign it thinking that's correct, because sadly 1 in 4 last year weren't. Also, you can check your rote's compliant by using our rote checking tool. So with that one, you can enter your rote onto the online tool, and it'll flag up to us wrong. Rote should be a bit more standard, so you should have less sort of issues there. So just a few figures in regards to that. We didn't check a small amount of contracts last year. We checked nearly 6,000, so 25% of those being wrong. Just too high a number, so do join. Let us check it, preferably before you signed it. Like I said, if you have signed it, we can still help and we can still get it rectified. But yeah, we're good in that department of getting things sorted, and we often get a lot of money back for doctors who've been on contracts for a long time, not knowing they're wrong, checked it with us, and we've got them thousands of pounds back. But we'd rather you just got it right from the get-go. So get it sent to us. Managed a lot of junior doctor cases. Managed last year almost 21,000. So if you find yourself needing some support, come to us. We'll help you through. We've got people on the ground at every trust. So we've got employment advisors. We've got industrial relations officers. We've got lots of people that are based at each trust and know HR and know who to know to get things sorted and to help you and support you and protect you. 1,600 rota queries answered. So rotas, again, like I said, should be a bit more standards, but really, if there's nothing else you take from this, just get your contract checked with us before you sign it, or just get it checked with us even after you signed it. So yeah, that's it from me. Like I said at the start, if you're not a member, good day to join, because you'll get 2.5 months free. Up to you what you do after October. Obviously, there should be sort of ballot and potential strike action after October, so hopefully stay on for that. But at least join, use that QR code. You'll get it free until October. You can get your contract checked, get your rota checked, and start using sort of the tools for F1. Yeah, that's it. I'm gonna cut it there. Thanks for listening, and good luck with everything. Enjoy the session too.
All right. Thank you, Daniel. So now I'm just going to play a video from our other sponsor, the MDU. Okay, so now I'm going to hand over to my colleague, Dr. Nihal Chanian, who's going to deliver his session on preparing for on-calls and common bleep scenarios. Again, don't forget to put your questions in the chat box and fill out the feedback forms, which we'll put the link to get your certificate of attendance. So here's over to Nihal.
Hi Hamza, can you hear me and see my screen?
Yeah, we can hear this. We can hear you well.
Perfect. So hi guys, my name is Nihal. I'm one of the junior doctors working in the West Midlands. Sorry about my voice today. I'm not very well, so my voice will be quite hoarse. I've got a blocked nose and a sore throat, so yeah, apologies before we start. I'll try my best. So today's talk's on calls, how to prepare for them, common bleep scenarios and how you respond to them. This is our 9th webinar in our 10-part FY1 Survival Guide Series. And yeah, we'll get going. Just a short disclaimer, this session will not teach you how to manage acutely unwell, deteriorating patients. There is a dedicated webinar for that on Thursday, the 28th of July, purely due to the fact that that webinar needs to be delivered by someone more experienced than ourselves. So it will be delivered by 2 medical registrars in our trust. And yeah, that will be on 28th of July, how to manage the deteriorating patient as an F1. So yeah, definitely stick around for that one, guys. The contents of today's session. So I'll just give you an introduction about what on-calls are and how we go about them, how to prepare for on-calls, how to recover from on-calls, a bit of general guidance, some of the common bleeps that you might face while working on the wards, and some scenarios. We'll go through those at the end. So what is an on-call shift? So an on-call shift is a shift where you're expected to work outside of your normal working hours, often for extended periods of time. You're expected to carry a bleep and respond to all your bleeps that you get. You typically must remain on site at all times unless you're a consultant. There's many different variations of on-calls. You can be on a day on-call, a night shift, a twilight shift. The hours vary between different departments. So, for example, surgery versus medicine. Again, there are different types of on-calls. So you could have an on-call where you're on ward cover, or an on-call where you're clerking new patients in. For example, if you're on a medical clerking on-call, you'll be seeing admissions from ED in the acute medical unit, and prescribing their regular medications and clerking them and taking histories and exams, etc. Whereas if you're on a surgical on-call, you'll be seeing patients in SAU most of the time, which is a surgical admissions unit. So what are the typical hours of an on-call? Surgical day on-calls often start at 8 and end at 8:30, and vice versa. Then night on-calls start at 8 p.m. and end at 8:30 a.m. Medical on-calls start normally a bit later, so they'll start at 9 and finish at 9:30, and the night team will start at 9 p.m. and finish at 9:30 a.m. Twilight shifts vary again. The general hours are from about 4 p.m. till midnight. And if you note between, so if let's take the surgical day versus night on call, there's a 30-minute overlap, both from 8 a.m. to 8:30 p.m. and 8 a.m. to 8:30 a.m. and 8 p.m. to 8:30 p.m. And that 30 minutes at each side is just to allow the day team to hand over to the night team and the night team to hand over to the day team in the morning. Okay. In terms of preparing for on-call, make sure you bring some food with you, especially when you're working on a weekend or you're working a night shift where there might not be any canteen or cafe options available. Bring some healthy food, so a good mixture of carbohydrates and protein. Often when you start on calls, there's a temptation, to just get a big energy rush and bring loads of energy drinks like Red Bulls and fast food you can order in the middle of the night. But trust me, you'll feel rubbish, and you'll probably crash in the morning, which will affect your performance as a doctor. So been there, done that, highly recommend against that. Before you're on calls, so you normally allocated into a block of on-calls, so you do like 4 on-call days in a row, or 3 on-call days in a row on a weekend, Friday, Saturday, Sunday. You need to organise your personal life before the on-call, so do anything like food shops, if you've got children, arrange childcare, etc. Because those days you're going to be so tired when you come back home after your 12.5-hour shifts. All you're going to want to do is go to sleep. So make sure you organise and prepare yourself as much as you can before you start your shift. Other things to do are, you're going to be walking around all day. Wear some comfortable shoes. Make sure you have the relevant equipment ready. So you need to bring your stethoscope, pen torch, tendon hammer, things like that. Ensure any useful apps are downloaded. So we did have a webinar on this called Preparing for FY1. It's on the medal page and the YouTube page. So it has a list of all the apps that you should download, and they're very useful for these on-call shifts because they can save you a lot of time, especially when clerking in patients. If you're on a night shift, you need to prepare your sleep pattern. Research has shown that typically the best way to do this is to, the night before a night shift, wake up as late as you can. So don't set any alarms in the morning. Wake up as late as you can. Try and, relax. Go to sleep at a normal late-ish time. Wake up as late as you can. And during the day, try and get another nap in, just to ensure you're fully rested for your nights. During the first night shift, you will feel very tired, and it will take you some time to adjust. So normally day 2 to 3, you've adjusted. And then day 4, you're so tired from your night shifts and your circadian rhythm's so disrupted that you'll crash again, but it's just how it is. Try and prepare yourself and get as much rest as possible. In terms of recovery, because these are 12.5-hour shifts, sometimes you can be too tired to drive home. And if it is at a level where you're so tired it's unsafe to drive, take a nap. Most hospitals will have resting facilities for doctors, whether that be somewhere around the doctor's mess or something you can arrange with your local department. But if you're too tired, there should be resting facilities available for you guys. If you've gone home to sleep, try and make sure that your sleep won't be disrupted. So things like blackout blinds, eye masks, earplugs, really, really useful to facilitate sleep, to make sure you don't wake up 2-3 hours after going to sleep. Some general guidance about on-calls. This is very general, and you'll pick up most of it when you actually do the work and you're on the job. So you need to learn some terms like take, post-take, and hot take. Take is when you, as a junior, clerk in a patient. So from AMU, for example, you clerk in a patient. That's a take. That patient's been taked, as we call it. Post-take is when it's been seen by a senior, so either a senior registrar or a consultant. And the difference between a post-take and a hot take is, a post-take is normally the next day after you've clocked in the patient. So you'll see a patient, run through a management plan, prescribe the relevant medications, and do the relevant investigations, get a series of steps for your management plan, and then that patient might stay overnight without review by a consultant until the morning. So then they'll be post-taken in the morning. Similarly, a hot take is just the same as a post take, but the consultant sees the patient essentially immediately after you've clocked them in. So it might be in the afternoon or the evening after you've clocked them in. If you're clerking, there's often a set performer set out by the department. This is true for most NHS trusts. So there'll be a medical performer for the AMU patients and a surgical performer for the surgical patients. It has lots of different sections which will remind you which parts to fill in. So just follow the performer and you can't really go wrong. Remember to prescribe the patient's regular medications. You can normally access these via the summary care records, which you use your smart card to access. And again, prescribe essentially every patient that comes into hospital VTE prophylaxis because they are immobile. They are at a high risk of having a VTE due to this immobility. But obviously, if they've come in with a bleed, don't prescribe them tinzaparin because you're going to further precipitate that bleed, and it's inappropriate in that sense. Typically, medical patients get prophylactic tinzaparin or low molecular weight heparin. Surgical patients get low molecular weight heparin as well as TED stockings. Keep an organised patient list. Again, the key to on-calls, preparing for on-calls and actually doing the on-calls is to stay organised. I know it sounds a cliche, but it will help you so much. Every patient you see, keep a note of the name, the ID number, what they've come in with, the jobs you have outstanding for them. So normally most of this can be on a patient sticker. So if there's stickers in the notes, if it's paper notes, get a sheet of paper, stick the patient sticker on, and write down any outstanding jobs. It will help you stay organised and make sure the shift runs a lot more smoothly. Take your rest. So in a period of 12 hours, you should have a minimum of 60 minutes rest. You can break this down into two rest breaks. So if you're working 9 till 9:30, try and have a rest around 1-2 p.m. and then another rest around 6 p.m. So make sure you have your rest. Stay hydrated, eat your food. It will help you be a lot more effective and functional as a doctor. And trust me, I've been there where it's so busy that you don't have time to even have a drink of water during the day. You don't have time to eat. So by the end of it, you're just completely non-functional. You're useless to anybody. So make sure you take your rest and have your drinks. Make sure you drink your water. At the end of your shift, make sure to hand over any outstanding jobs. Use SBAR to hand over because when you're receiving handover, it's not very nice when you don't know much about the patient. So basic things when you're handing over a patient: the patient's name, their patient identification number, their location, a bit about what they've come in with. So this patient was admitted with community-acquired pneumonia. A bit about their background, so what past medical history is. So do they have COPD, do they have asthma, etc. And then again, what your assessment is, what your investigations are, what you want the person to actually do. Is it to chase a job? Is it to do a job? Most jobs are appropriate to hand over, and there are a few exceptions. Things that are non-urgent that can be done in the daytime, they don't need to be handed over. Things that would take longer for you to hand over than to actually do yourself, something like a PR exam. It's not really appropriate to do a PR exam. I mean, the only case in which a PR exam would be emergency for you suspecting something like cordial equina, in which case you'd better be doing the PR exam yourself. Okay, now we'll run on to some common bleeps. So these are some of the most common bleeps you'll get while you're working as an FY1. Some of them are a bit frustrating, some of them are very important, and you'll get used to filtering out the important ones. So we'll go through them. So patient needs a cannula. Patient needs bloods taking in the middle of the night for gentamicin or vancomycin level. Patient needs a catheter. Patient has fallen, they need a review. Patient has low blood pressure. Patient needs antiemetics, analgesia. Patient is scoring, so they've got a U score of greater than 4, or they've got a U's of 2 or 3 in one parameter. And there are many variations of this, so you could get called about a patient who's tachypneic, tachycardic, hypertensive, etc. So very many variations of this, and you'll learn how to manage each one individually. But I'll give you a quick whistle-stop tour of some of the most common bleeps and how we sort of go about them. So, patient needs a cannula. If I get this bleep, I make sure to ask a few important questions. So if I'm on a night shift, I'll ask, why does the patient need a cannula? So if they tell me it's for fluids, I'll ask them for the patient details, for example. Fluids are only really urgent if the patient is nil by mouth or in acute kidney injury. So I remember a consultant saying to me when I was prescribing fluids manically overnight, do you drink fluids overnight when you're asleep? No, you don't. So why are you prescribing the patients fluids overnight and making sure they're continually having fluids? No, it's not something that's urgent overnight. If you have time to cannulate a patient for fluids, go ahead. But if you've got other things that you need to prioritize, which you most likely will have because these shifts are very busy, then you shouldn't be doing that. If the patient needs IV antibiotics, that's an indication for a bit more of an urgent cannula. Again, nil by mouth we mentioned before. What's happened to their previous cannula? I always ask them this: has it fallen out? Has it tissue? They might just say, "Oh, it's not working. It's not flushing properly." I'll then go and see the patient, look at the cannula, flush it myself, and it flushes perfectly fine. So make sure to check that. Sometimes cannulas are working perfectly fine. You think, why am I having to recannulate this patient? And again, another important question is, has anyone attempted to insert this cannula on the ward? So as a general rule of thumb, a nurse should always attempt a cannula before a junior doctor or an F1. If a nurse calls me and says, I've attempted this cannula, I've been unsuccessful, would you mind having a go? I say, absolutely, that's fine. As long as you've had a go, and it might be a difficult patient, there's no need to stab them multiple times. I'll come and have a go. The general line of escalation for these sort of things like bloods and cannulas is the nurse should attempt it first. They fail the F1, SHO, SPR, and if the SPR can't do it, the registrar, then we'll have to get the anaesthetist in. They'll often have to use ultrasound for these very difficult cannulas, patients with collapsed veins, tiny veins, cord peripheries, etc. The anaesthetic registrars will only really cannulate patients if the prior people have attempted and failed. So, like I've said, the nurse, F1, SHO, reg. So make sure you escalate appropriately if you can't do it. Normally, if it's an urgent cannula, I'll have about 3 goes before I say this is enough. There's no point distressing the patient, especially if they're needle phobic. No point continually stabbing them if you're not being successful. Again, remember about prioritization. If you've got a patient scoring an 8, and the nurse says to you, you urgently need a cannula for another patient, what are you going to do? You're going to see the patient who's scoring an 8, or you're going to do a cannula. So again, you have to prioritize your jobs. Cannulas, they can be urgent, but in some circumstances they're not so urgent. So make sure you find out what it's for. Another common bleep that I'm getting at the moment is a patient needs blood tests for gentamicin levels. So if you're on surgery for your first placement as F1, you'll have a lot of patients on gentamicin, vancomycin, essentially because we give a lot of patients with potential abdominal infections, triple antibiotic therapy. So that would be amoxicillin, metronidazole, gentamicin. And so if you've got a patient who's had or received their gentamicin dose at 4 o'clock or 4 p.m., every patient who has gentamicin dose needs a post-dose level 6 to 14 hours after their dose every 3 days. So if they've had their dose at 4 p.m., they'll need a level check at 10 p.m. to 6 a.m. Again, that will fall to the FY1 on the night shift. So again, it is important because with gentamicin there's risks of renal toxicity and ototoxicity. So I'd always check the renal function, a dose every 3 days. Remember about the line of escalation I mentioned earlier. So has the nurse had a go at taking the gentamicin level? Because you've got to remember during these on-call shifts you are covering multiple wards, multiple unwell patients, and nurses are typically allocated a bay and a half, so 6 to 9 patients. So it's busy for everyone, but you have to prioritize and escalate appropriately. Similarly with vancomycin, you need a pre-dose level or a trough level, checking every 3 days to monitor your vancomycin doses. There's a risk of renal toxicity, so it is again important. Again, with prescribing these, don't be scared if you're not sure how to do these things. Ask your SHOs, ask your registrars, refer to your local antibiotic policies, and if it's during a daytime shift, contact the microbiologist on call. I wouldn't contact a consultant microbiologist at 3 a.m. at night for a gentamicin level advice. That would be inappropriate. But if it's during the daytime and you need to get some advice, go ahead, escalate. Remember about your line of escalation, like we said earlier. Remember about prioritization. So next common bleep, the patient needs a catheter. So you get this quite a lot again on surgery, sometimes on medicine. You need to ask some questions first before you go up to the ward and put a catheter in. What is the indication for the catheter? Is the patient in retention? Are they septic? Do they have end-stage AKI? Do they have dysuria, for example? Some of these might not even be, some of the things that they call you for might not even require a catheter. So you need to filter it out and find out what's going on. If they're in retention, has a bladder scan been done? because the nurse might say he's in retention. Do a bladder scan. There might be 100 mils in the bladder, so this is important to establish before you go and stick a catheter in. Again, there's different types of catheters: short versus long-term, two-way catheters versus three-way catheters. With three-way catheters, you'd only really insert them. Essentially, they're for irrigation. So if a patient has clots and they're passing blood clots, they can get painful stuck in the urethra. So you need to insert a three-way catheter to sort of irrigate the bladder and wash out the clots. But this is something you should, if you're not sure about, that's totally normal. I remember being asked to do a three-way catheter in my first week of being in F1, and I had no idea what to do. I was like, how do I even do that? I know how to do two-way, not three-way. Most SHOs, Regis will be happy to show you. And if it is, a proper difficult urology case and there's loads of clots, it'd be worth contacting the urology reg, because that really should be someone you should be escalating to in this instance. Generally, around 500 mils retention is considered to be significant with catheterization. Another thing that I had once was a nurse told me there was 2 liters of urine in the bladder. And I sat there thinking to myself, 2 liters of urine in the bladder? That doesn't really make sense. That's a milk bottle. That's like a 2-liter milk bottle. That doesn't make sense at all. Turned out the patient had dense ascites, and the bladder scanner was picking up the fluid in the abdomen rather than the bladder. And when someone else did catheterize the patient, no urine came out. Urine did come out. It was a couple of, I think, 50 mils or something, so nothing much. But make sure that the patient needs a catheter if you're asked to catheterize a patient. And typically, a nurse is generally expected to be able to catheterize patients of their own gender. So with female nurses, they're typically expected to catheterize female patients. Again, with male nurses, typically expected to catheterize male patients. If it's a nurse of the opposite gender to the patient, then it's appropriate for you to be called to go and catheterize the patient. You might need help from the nurse or the HCA just to act as a chaperone, but in that instance, it would be appropriate for you to catheterize. Moving on. Patient has fallen over. This is a common bleep scenario you'll get. Every patient who has a fall in hospital needs to have a doctor review. So the important questions to ask are, was the fall witnessed or was it unwitnessed? Is the patient anticoagulated? Did they hit their head or injure any part of their body? And again, when you actually go to the patient, you'll need to take a thorough history and do a full body exam. When I say full body exam, I mean full body exam, full MSK exam to make sure they haven't injured any of their joints, neuro exam, assess their GCS. It might even be appropriate to do a cardiovascular, respiratory, gastro exam, depending on what part of the body they're injured. So, thorough history, full body exam, and then arrange the appropriate investigations. If a patient's fallen over and banged their head on a radiator, you need to arrange a CT head. Otherwise you're potentially liable to something there. So, there are certain important investigations you need to arrange, to rule out pathology. Appropriate measures should be put in place to prevent this occurring again. So they should have a falls risk wristband. And so nurses should be keeping a close eye on them. If they need to go to the bathroom, etc., they should be escorted by someone. They shouldn't be able to go alone. The bed rails on the sides might be up to prevent them falling out of bed. They might have a low set bed, so a mattress low on the floor to stop them from falling over. Another common bleep: patient has low blood pressure. So this is, this could be a worrying one. When someone says low blood pressure, 90/50 or 80/60, you always think, they've gone into shock. Different types of shock: septic shock, hypovolemic shock, cardiogenic, neurogenic shock. You need to establish whether this is a normal blood pressure drop or if it's something more significant. So most patients in hospital, on a ward, they're lying in bed, they're staying still, their blood pressure is going to drop. Okay, this is a fact. They can become bradycardic, they can become hypertensive. They're lying in bed, they're doing nothing. This is normal for them. Okay, go and have a look at the patient. How do they look from the end of the bed? Are they comfortable sitting upright reading a book? Are they sweating with their chest rising rapidly? Short of breath. Looking at the patient from the end of the bed is a very important indicator of how they're doing, and how you can assess them. What's the patient's baseline BP? So if I'm bleep to see a patient whose blood pressure is 95/60, and then I look in the past few days, it's been 90 to 100, and that's normal for them. So it does depend on the patient. It can vary depending on from patient to patient. Someone's baseline could be 160, someone's could be 90. So just have a look at their baseline BP and their previous observations. So again, have a look at their other observations when the nurse says they've got low blood pressure. So are they tachycardic? So if someone's hypertensive and tachycardic, that would make me worry in terms of some kind of shock. Look at the other obs. So are they tachypneic? Are they desaturating? These sort of things can sort of put you towards a direction where you think, okay, maybe I need to arrange some further investigations for this patient and escalate to a senior. Is the patient on any fluids? So a patient could have a blood pressure drop, and actually they're meant to be on Hartmann's or normal Matalite or sodium chloride, and it's not been prescribed for 2 days. So you can think about, do they need prescribing fluids? Typical fluids are prescribed about a litre over 8 hours, or if the patient's more elderly and they've got a weaker heart. So again, issue of CCF, congestive cardiac failure, we'd extend it for maybe a litre over 12 hours, or if they were acutely dropping their blood pressure, would give a 250 ml bolus as opposed to a 500 ml bolus. Patient is in pain, so it's important to ask why the patient needs. This is again a common bleep. It's important to ask why the patient needs analgesia. So if a nurse bleeps you and says, my patient needs paracetamol, and you go, why? They're having new chest pain. Now, believe me, this can and will happen, and it does happen. Okay, you need to ask why they want you to do what they want you to do. So, again, in this case, you'd go up there immediately and do a full workup for the patient, ECG, bloods including troponin, etc. But yeah, you need to ask why they need the analgesia. The most commonly used analgesic in hospitals is paracetamol. We normally give a gram, so 2 tablets 4 times a day, unless they have severely deranged liver function or they are underweight. So normally under 45 kilos, you'd have to have a bit of a lower dose. I think it's half dose paracetamol. That's not working. We can, step it up to cocodamol or codeine. Remember, if you're giving them cocodamol, you have to cancel the paracetamol, because then you'll essentially be giving them, if you don't cancel the paracetamol, you'll be double dosing them with paracetamol, which can be fatal. So be careful with these ones, guys. Codeine, again, is another good one. Remember, it's constipating, so you don't want to give it in certain patients with bowel pathology. NSAIDs can be useful, so for example, ureteric stones, certain forms of arthritis, etc. In surgery, we typically give Oramorph solution if the pain is severe. So we can give it every 4 to 6 hours, sort of 10 milligrams per 5 ml solution, maximum 60 milligrams in a day. If the patient's having all these things, paracetamol, Oramorph, and they're still in severe pain, you might need to escalate this with your registrar. It may be the case that the patient needs an opioid patch or a PCA pump. So, if the patient's still in severe pain after having morphine solution orally, then there might be something more significant going on. Again, some patients are, they're crying out for pain relief because it makes them feel good, etc. You have to be wary of that, but always investigate further. So we're going to run through some scenarios. Hamza, if I can invite you to join back in with me now. I'm just going to ask the audience some questions, and I'd like them to type in the chat what they think would be the most appropriate thing to do.
Mm-hmm. Yeah.
Yep, so we'll just make a start. So, first scenario. Hi, doctor. This is one of the nurses on ward 35. I need you to quickly prescribe some paracetamol for my patient. It will only take 1 minute. She's spiking her temperature. So just read that and take it in, okay? What questions do you ask the nurse? I'll give you guys a minute or so to answer that.
So again, put your answers in the chat box and I'll relay it to Nihal. Okay, so we have a few responses coming in, Nihal.
Perfect. Do you want to read them out, Hamza?
Yeah. Naina has said, you'd ask the nurse, is there any other problem?
Yeah.
Amy has said, you'd ask the nurse, what is the temperature?
Yeah.
You'd also ask, what's the patient's latest vital signs or news score?
Yeah, so we'll run through things. These are some of the questions we'd ask. So again, we want the patient details. Often, if you're getting a call from a bleep, you want to have a computer in front of you, signed in, so you can get the patient ID number, search it up, and look at the observations and so forth from wherever you are in the hospital. Because it's important. You can handle certain things over the phone. Other things you need to go and see the patient. So patient details. We need to know what exactly the temperature is. What is the patient's situation and background? So what are they in for? What medical conditions do they have? What significant medical conditions do they have? Is the patient on any antibiotics? What are the patient's observations? Okay. So the nurse tells you the patient has a temperature of 38.5. The patient is 7 days post-operative from a Hartmann's procedure. The patient is not on any antibiotics. Other observations are stable aside from the patient's respiratory rate, which is 24. So I'll give you a bit to take that in and read that. What do you do next? If you could type your answers in the chat box, we'll give it a minute or two just to see if anyone has any responses. Remember, you guys aren't even F1s yet, so don't worry. Just anything that comes to mind, just pop it in the chat.
And for those of you that don't know, Hartmann's procedure is just a procedure where you remove part of the bowel. So it's usually an emergency procedure. It could be due to cancer or perforation or anything like that.
Yeah, thanks for clarifying that, Hamza.
So we have a few responses coming in, Nihal.
Yeah.
So the people are saying you'd assess the patient, assess the surgical site. You'd also query for a leak. You do a full A to E assessment. You do some blood cultures. You go see the patient. Are you thinking, is this patient septic at the moment? And we have a few responses about blood cultures and doing A to E assessment.
Perfect. So, yeah, essentially, at this instance, you do a full history and A2E exam of the patient, like you've been taught in medical school, like all of you know. Patient tells you they feel generally unwell, but they can't pinpoint what is wrong with them. The abdomen is actually soft and non-tender. You do, however, hear some crepitations at the left lung base. What would you do from this point? I think you guys have already mentioned this, so we can run through the answers here. So, we need to do a full septic screen, blood cultures, chest X-ray, urine dipstick, and/or MSU. I typically do both urine dip and MSU. COVID PCR test, bloods including full blood count, UNE, and CRP if not recently done. The patient needs to be started on antibiotics. So if they're spiking temps, 38.5, we'll start them on, typically for chest infection, it would be amoxicillin. And we'll give some fluids and paracetamol to obviously control the temperature. So in this instance, although the patient's had a Hartmann's procedure, the abdomen's soft, non-tender, what is the most likely diagnosis?
So again, put your answers in the chat.
Do you have any answers, Hamza?
Yeah, so we have atelectasis and hospital-acquired pneumonia.
Yeah, so actually it could be atelectasis. again, it could be the most likely diagnosis is hospital-acquired pneumonia, and again, they could actually they could have a collection in the abdomen. It's more unlikely because you've heard creps in the lung and the abdomen's soft, but it's always a possibility. So we need to do the chest X-ray to rule out any sort of chest infection, and then when a senior sees this patient next, they'll see a documentation. And again, they'll review the patient and to check for any abdominal collection or anything like that. But in this instance, it's most likely hospital-acquired pneumonia. So we'll run through another scenario. I'm just wary of time because I know we have to do a Q&A and it's coming up to the hour now. So you are walking off a ward when you overhear two healthcare assistants talking about how a patient has fallen out of their bed again. But it's okay, she got back up and got back into bed. What questions do you ask the healthcare assistants or a nurse looking after the patient? If you just type your answers in the chat box, guys. Do we have any answers, Hamza?
No, not. Feel free to answer, guys. Remember, there's no right or wrong answer.
Yeah.
We're all learning here. Okay, so yeah, we have a few answers now. You'd asked about the patient ID, what they've come into hospital for, and their past medical history or anything that's happened prior to that fall. Was the fall witnessed or not? Is the patient on anticoagulant and did they injure themselves or hit their head?
Perfect. So all those things are correct.
And is this patient epileptic? So I guess the past medical history of this patient.
Yeah, it's all relevant. Was the fall witnessed or unwitnessed? Did the patient hit the head or hit anything? Are they anticoagulated? You'd want to have a look at the drug card. Do we have a set of observations following the fall? What's the situation and background of the patient? So like you've all said, we need to know a bit of details about what's been going on. They tell you the fall was not witnessed. The patient is known to have falls due to being frail and being mechanically unstable. She's in hospital for medical management of pyelonephritis. Observations following the fall are the same as prior to the fall. What do you do next? This is quite an easy one, guys, so don't worry about this. It's what you've all been taught in medical school. Do we have any answers, Hamza?
Examine the patient. Are there falls? Do a falls risk assessment. Anything else you guys would do? Examination of the vital signs. Check for GCS. Take a history. Do a full body physical exam. So I guess that's an A2E.
Yeah. So again, take a thorough history and perform an A2E exam is the correct answer. So it's not complicated, guys. You guys all know this. And they drill it into you in medical school, A2E exam, but it really does come into use on the wards and during your on calls. So make sure to use it, guys, and you won't miss anything. So you try to take a history from the patient, but she has very limited communication. You feel as though she's confused. Otherwise, eyes are open spontaneously, and she is localizing to pain but not following commands. There is no actual focal neurology, and other examinations are normal. So, what do you first need to establish, and what do you need to do next?
So we have a few answers coming in. Is this patient hemodynamically stable?
Yeah.
Anything else, guys, you want to know? Is this new confusion?
Yeah, that's very important. Yeah. Yeah, so we'll run through the answers.
Okay.
So you need to establish the patient's baseline GCS. This could be normal for her. As is the case, when I've clerked many patients, many frail old patients in AMU, some of these elderly patients, they have chronic confusion. They often won't follow commands, and that's perfectly normal for them. So we could be, we could be over investigating this patient. It could be unwarranted. So you need to establish their baseline, assess what's normal for them, withhold any anticoagulation or antiplatelets, place the patient on neurobes every 30 minutes. That's quite important. The nurses should know that, but sometimes you will have to remind them and document it in the notes. So any patient who's had a fall and hit their head, typically neurobes every 30 minutes to monitor for deterioration. And, the nurses should be monitoring this. They should know about it, but make sure to document it, guys. And they'll do certain things. So they'll assess GCS, they'll assess motor function, left and right side, pupils, etc. But it's quite important with patients with head injuries. If this is not her baseline GCS, you need to arrange an urgent CT head scan. So the nurse tells you her baseline GCS is actually 15 out of 15. So you go ahead and arrange an urgent CT head, which is reported within 10 minutes, and you get an emergency phone call from the on-call radiologist. The patient has an acute subdural hemorrhage. Who are you meant to escalate this to?
The stroke team, MedReg, neurosurgeons, the Reg.
Yeah. So this patient's been admitted for medical management of pyelonephritis. I think we said, we said medical management of pyelonephritis. So a bit of a side note, pyelonephritis, there's medical causes and there's surgical causes. So depending on the cause, it depends on which team they go under. So this patient's under medics for medical management. So we'd escalate to our medical registrar, who would most likely tell you to also escalate to the neurosurgeon. So you'd escalate to both essentially. You'd talk to your reg and then also talk to the on-call neurosurgeon. It may be the case I want to do something in this patient. It's unlikely. We've mentioned they're very frail, elderly, mechanically unstable. So pretty poor functional status. Neurosurgeons are unlikely to do anything, but you have to escalate. That's an important part of your job. So you've escalated this to the neurosurgeons and your medical registrar. They'll come and review the patient. What do you do? What do you need to do before you leave the ward? So you've escalated. The relevant people are on their way. What are some last minute things you need to do before you leave the ward?
Document everything that has happened in the notes.
Yeah. Anything else?
Nothing at the moment.
That's fine. So I've not included it here, but what you've just mentioned in the chat, documentation, very, very, very important. You essentially most things you do with things like with especially falls, you need to document in the notes. Because if you don't document, you could be held liable, essentially. So yeah, you see a patient, you perform an A2E exam, you document that every single time, guys. If it's something little, like I don't know, prescribing some paracetamol for some pain, you don't need to document that in the notes, guys. If you insert a cannula for a patient, you don't need to document that in the notes, okay? So you have to see, you'll learn this on the job, but certain things you're meant to document, certain things you're not meant to document. And if you're wondering, what should I document, what should I not document, you can ask your queries in the chat, and we'll discuss those in the Q&A session. But essentially, things I've got down here are you need to submit a DATEX. So any patient who has a falls risk, so this patient was already a falls risk. She was known to the staff to have to be frail and elderly and to be mechanically unstable, and she's falling over again. That needs to be DATEX because it's a patient safety incident. We need to prevent this from happening in the future. We need to submit a DATEX, and we need to ensure the relevant appropriate safety measures are in place so the patient does not fall again. So, like we said before, a low set bed, the rails on the sides of the bed should be up so the patient can't fall over. Exceptions to that are if the patient, is very agitated and doesn't like confinement. It depends from patient to patient, but you need to put the relevant safety measures in place. Double check any anticoagulation and antiplatelets are withheld. You don't want to further precipitate this bleed. You might cross off the low molecular weight heparin, and then 20 minutes later, the nurse might give them aspirin. Okay, so you need to be very careful with this and make sure you withhold those meds when a patient's had an acute subdural bleed like this one. Again, and ensure the nurses are aware that the patient needs to undergo neuroobs every 30 minutes to monitor for deterioration. And with that one, neuroobs for patients with neurological injuries or head injuries, typically you do neuroobs for about 30 minutes following the incident. And then after that, it varies. So it could be 2-hourly or 4-hourly, but it varies from trust to trust. So just check your local guidelines, guys. So yeah, that's the end of the talk. I hope you found it informative. I'd just like to talk a bit about our webinar series. So we've got 10 webinars. This is webinar 9 of the 10-part series. The first 8 webinars are available on Medall and YouTube. I'd make sure to attend the big one, which is our final one, Managing the Deteriorating Patient. That's on Thursday, the 28th of July. And in that talk, we'll have a dedicated 90 minutes, I think, for 2 medical registrars discussing U-scores. So patient scoring an 8, patient very unwell. This is what's going on. How do you handle it as an F1? So that's I wouldn't miss that talk if I were you guys. So make sure you schedule that one in your notebooks. We've also got a Prepare for FY1 course. It's free. There are identical courses based in Liverpool, London, and Sheffield. It's simulation based. Last year, confidence in FY1 rose significantly. It's almost sold out, and I think some of the events are actually occurring this weekend. So a few slots have come up from people withdrawing late. So if you really want to go on this free Prepare for FY1 course, contact Mind the Bleep on Facebook Messenger, or via email at mindthebleep@gmail.com. Probably Facebook is better to get a response. That would be quite a good course to attend. And finally, any questions to you guys? Here's a barcode to scan to give any feedback. We can run through a Q&A, guys, now. So Hamza, would you like to come back?
Yeah, sure. I posted the link for the feedback form as well in the chat, so don't forget, on filling out your feedback forms, you get your certificate of attendance, which you can use for your portfolio. So now we're going to have a Q&A session with Nihal. Feel free to put any questions in the chat and Nihal will answer them.
And again, guys, I apologise for my voice. I'm not very well right now, but I thought I'd push through and give this talk for you guys because I'm doing so much for the incoming doctors next year.
He's dedicated.
I'm dedicated, yeah.
So a question, Nihal, we've had during the talk is someone just wanted clarification on the cannulas in terms of the level to which you would escalate. So who would first try the cannula, and then if you fail, who does it go on to next?
So the nurses should try the cannula first. All nurses have been trained, when they've undergone their degrees in taking bloods and cannulas. So it should be the nurses doing it first. You might get you will get a lot of bleeps from nurses asking you to do bloods and cannulas, but when there's 3 doctors looking after 6 or 7 surgical wards or medical wards, you can't be expected to do those things. So only if it's urgent, okay? And if someone else has failed. So the escalation order is nurses, then FY1s, then any SHOs, so FY2s or FY3s, core surgical trainees, core medical trainees after that. And if they've all tried and failed, you'd escalate to the registrar, or they would escalate to the registrar, who would then, if they failed, call the anaesthetic reg. Worst case scenario is the anaesthetic reg comes along with an ultrasound machine, can't get IV access. They need to probably then insert a central line or something. I've seen it happen once or twice. But yeah, it's an interesting scenario when it happens because they are experts in cannulating, getting IV access, and if they can't do it with ultrasound, then it's obviously a really difficult one. So yeah, I think we had a case the other week where a patient with he was in DKA, and we couldn't get a single cannula on him. And patients with DKA need 2 cannulas, one for fluids, one for insulin. So that was an emergency scenario where we escalated up the line and we couldn't get an anaesthetic reg who could actually do it. And I think they had to get the consultant in to come and take the patient to theatre to get IV access in the central line. So yeah, that's the order of escalation.
So we have another question about documentation. When do you document certain medications? You mentioned not paracetamol. Any other medications you wouldn't really document if you were prescribed?
I wouldn't document most medications, to be honest, purely because you'll learn on the job that you're so busy. If you prescribe something like PCA, so patient-controlled analgesia of morphine or fentanyl, that will need documenting somewhere. Likewise, any controlled drugs. So as an F1, you shouldn't be prescribing things like methotrexate, but you will be prescribing things like Oromorph or codeine. Codeine you don't need to document. Oromorph you don't really need to document. It would be something like something like PCA you need to document, or it would be in a plan where you'd say start the patient on a fentanyl patch or a PCA, those sort of things.
Thank you, Nihal. Another question: if you're unsure about how to prioritize the on-call patients you get bleeped about, who do you ask?
If you're unsure about how to prioritize the on-call patients you get bleeped about, who do you ask? So I'm assuming you're saying you've got many bleeps and you don't know how to prioritize. In the first instance, if there's no emergencies, I would ask my SHO and say, I've got all these bleeps, I need to see all these patients. Who do I prioritize? Who do I go and see first? In the first few weeks of F1, your SHOs will be happy to help because they've been there before. They know how it works. They know how little they knew at the start of F1. Not medically, but just experience-wise. So yeah, I'd escalate to your SHO. And if you do have a patient who's very unwell, then obviously escalate to your registrar. Any more questions, guys?
So do you take bloods yourself whilst on call?
So I'm on call in surgery at the moment. I don't take bloods myself. Sometimes I do. So if the HCA or the nurse is busy and I can see everyone's short-staffed, then while I'm clerking the patient in, taking a history, I'll often just put a cannula in and take bloods off the back of the cannula. It just saves everyone time, doesn't it? So sometimes I do it. Everyone's busy, everyone's working hard. So sometimes I do it, sometimes I don't. It just depends on the circumstance, and you'll learn that with experience. If if you're getting bleeped to a ward to take blood, then that's not when you wouldn't do those things really. You'd get someone else to have a go first before you tried it. So if you're clerking a patient, sometimes you would, but if you're being bleeped to the wards or you're on ward cover, then you wouldn't normally be doing it, no. And again, there are certain circumstances when there are unwell patients, for example, they're septic or they're in severe AKI, and in those instances, I would take bloods myself just because I want to get a result back quickly. So yeah, it just depends on the circumstance, and you'll learn that with experience.
Again, this will depend on where you work, which hospitals as well. For instance, I know some of the hospitals in London, the nurses can do a lot, so they will take bloods, whereas in other hospitals, a lot of the nurses can take bloods, but they're not certified by the trust, so they won't be allowed to do them, so then it'll fall on you. And as Nihal pointed in his presentation, again, it depends on the situation of why you're taking bloods. If you're taking bloods for something that won't change the management plan during your night shift, you're on call, so that won't be a priority. But if it's for something urgent, then yes, you would take it. Do we have any more questions, guys? So someone has just asked, they have their rota, but how do they know which ones are the on-call days, for instance?
Yeah, so your rota should have a key, and different days should be coloured in different colours. So you might have your ward cover on calls coloured in orange, for example, and in the key it will say ward cover, and you might have your clerking on call shifts in purple, and that will say clerking or admission. Your normal working hours are typically in surgery it's 8 till 5, in medicine it's 9 till 5. So anything that goes beyond that or is in a weird sort of working hour time slot is typically an on-call shift. So for example, if it has the time and it says 8 till 8:30 or 9 till 9:30, then you'll know it's an on-call. But if it says 9 till 5, that won't be an on-call. Hope that clears things up. Any more questions, guys? Feel free to ask anything. There's no judgment from us. I knew absolutely nothing before I started F1.
Same here.
I don't think we have any more questions, Hamza.
No, I think that's it.
Should we call it a day?
Yeah. So just don't forget to fill out your feedback form to get your certificate of attendance. This session is being recorded, will be available to rewatch on the Mind the Bleep YouTube channel and Meadow.
Yeah, thanks very much for listening, guys. Good luck with F1. Remember to attend our talk in 2 weeks, which will be delivered by 2 experienced medical registrars. A lot of this you'll learn on the job. It will come with experience. You'll be fine. Okay, good luck, guys.
Thank you, Nihal.
Thanks. Take care.